Good morning, everyone. My name is Gloria Brand, and I am the director of the Program in Opioid and Pain and Innovation here at the Brigham and Women's Health. And we are also joined by the Center of Global and Health Delivery, which is over at Harvard's Medical School. We welcome you all who are attending this series. This is the fourth session of our global series. And today we'll be featuring Vietnam with Dr. Robert Heimer, who's a professor at Yale University School of Public Health. Dr. Heimer is also a professor of pharmacology at Yale and has spent the last three decades conducting research at the intersection of infectious diseases and substance abuse. We also are delighted to have John Hamilton here with us today. He's the president and CEO of Liberation Programs. John Hamilton has previously served as the agency's vice president of clinical services and the senior vice president from 1996 to 2006. And he's nationally recognized as an expert in the field of addiction treatment and prevention, and brings 3 decades of experience to his role. So we're so excited again. They're going to delve off into some really great information around substance use disorder policies within the Vietnam space. But we wanted to just give a quick intro. Today, we're going to have Dr. Heimer go first. John will follow him, and from there, we'll have questions and answers from our audience. Feel free to use the question and answer feature in your Zoom box. And Dr. Heimer, please go ahead. You have the floor.
Thank you. And good afternoon, everyone. The talk I'm going to give today is sort of off the cuff and kind of anecdotal, just because of the way I got involved with this is more of a story than a research project. I first met Wong Cot, who was from Vietnam, when she came to Yale to be a World AIDS Fellow. Now, the World AIDS Fellows program at Yale invites people who are mid-career, but people from their home countries who are growing in world recognition to come and spend a semester at Yale and basically feel free to do whatever they want to do. One of our most illustrious alums has been in the news lately. Alexander Navalny came in 2010. Wang came in 2003, and I met her because she was interested in the issues of HIV and drug use in Vietnam, and I'd been doing work on HIV and drug use, working with the establishment and evaluation of needle exchange programs for a decade at that time. And we met and we talked, and I went through the things that we knew about the advantages of using needle exchange to enroll people in substitution treatment for opiate use disorder, and learned that there was none of such things in Vietnam. There was no medication-based treatment, although there was syringe exchange, and that her organization was involved with empowering drug users to run these organizations themselves. When she returned to Vietnam, she pushed the government through her agency. She had the ear of powerful people, and she encouraged them to consider opening the country up to medication-based treatment. At that point, it was predominantly methadone. Buprenorphine was just being approved for use in the US just a couple of years earlier. And at some point, I was invited by her to come and visit and talk to people and present information about the biological basis of addiction and the biological and medical data supporting medication-based treatment. Now, this was something that was intriguing to me. How do you get people who are not trained, like I was, in pharmacology, not trained in medicine, not trained in public health, to think and understand that opiate use disorder is a chronic relapsing condition, that abstinence-based treatments fail 90% of the time within 6 months, that we already in the US had a 40-year history in the early noughts, mid-noughts, a 40-year history of treating opiate use disorder effectively with methadone. And how do you get them to appreciate that people who've developed opiate use disorder, moderate to severe opiate use disorder, are not simply weak-willed, simply not hedonists, simply not people who have a deviant streak, but are people with a medical problem who need treatment, and where the gold standard treatment is medication. So what Wang had arranged, and what I'm going to do is share, if I can, a picture of Wang and her husband, Dominique. Just so you know what she looks like, because that's not the picture. Which is the picture? Should be this one. No, why is it showing the wrong one, even though I'm clicking on the right one? Well, maybe I can't do that. Let's try the other one and see what happens. Nope, I only get that one. Oh, it was there. Let's try it. Can you see that?
It looked like one before.
Yeah. Can you see it now? No.
No,
Let me try once more, and then I will go on.
I got a photo of her as well. I'll show later.
We have not planned this, so that let's try it once more. It's this picture here. Can you see that now?
There it is.
That's Wang and her husband. Now, Wang is very diminutive Vietnamese woman, but amazingly powerful. And what she arranged for us to do was to give a series of lectures in Hanoi to leadership groups. And the groups we talked to were not your standard public health officials, which you might have thought would be doing, or people in the Ministry of Health. We talked to the staff of the Vietnamese National Congress, which meets every so often to enact new laws. But the delegates to the Congress are part-time people. There is a permanent staff, just like there's a permanent staff of people in Washington, D.C. for our Congress, and they're the ones who basically write the legislation that then appears on the desks of people when they come to vote on various pieces of legislation. And so I briefed these people about what constituted opiate use and how it affected the brain, how it was a long-term chronic problem if it became problematic use, what the treatments were. I also gave 3 other talks during that time. One to the journalists who would be writing about the legislation, the print and the TV and radio media about the issue of addiction. Equally important to talking with the journalists, I talked to the editors of all of these magazines and newspapers and the leadership at the radio and TV stations, because they were the ones who were going to be deciding what the journalists could actually cover. And then I did talk to physicians and public health officials at the medical university. So basically, this set the stage then for writing a um, a, a, a document to put on the desks of the legislators when they came that would brief them about the need to change the rules. And this is the English version of what appeared on their desks. This is the draft version. It was translated, obviously, into Vietnamese and given to all of the legislators once they arrived. And at that point, within a very short period of time, in 2005, methadone treatment went from being forbidden to being voted on. Now, I'm not going to take sole credit for this. At the same time, Wong had arranged for delegations of people from other Asian countries that had begun to scale up methadone or had scaled up methadone to come and visit. Visiting group of treatment professionals from Malaysia. China had just recently gone from 0 methadone to 1,000 methadone clinics in 5 years. A delegation came from China, a delegation came from Central Asia, where again, methadone was being rolled out for the first time after having been illegal under the, the old Soviet system. It's interesting the multi-pronged effort that was done to convince the Ministry of Health, the Ministry of Education, the local government officials, the National Congress, the people who were overseeing the corrections system, which in Vietnam, there's a multi-tiered incarceration system for people with drug use problems. There's sort of the standard, what you'd think of as the Western jail prison system for people who are breaking the law, who get caught, who are convicted of crimes and are sent away to jail and prison. There's a separate system, a re-education system. And this re-education system is essentially something that's being attempted in parts of the United States now, which is an involuntary detention system in which people's families that are worried about their family members' drug use basically refer their family members for involuntary detention, and they can be put in these 6 prison camps. They really are prison camps for 6 months or a year or 2 years, where they receive no real treatment except absence of drugs for the length of their stay, and then they're released again without really any kind of attempt to provide them with any kind of effective treatment for their opiate use disorder. So we had to convince the people who ran these camps that they were seeing the same people over and over again, and it wasn't really working. Unfortunately, it was a little more complicated than that because these camps were, in fact, enforced workhouses where the people who were detained there would go through their rehabilitation, was working for virtually no money to do, manual labor or piecework for the owners of the detention centers who were profiting from their labor. So they were initially a little reluctant to change their system, which was creating for them a source of wealth. But eventually, their reservations were, I think because of higher government intervention, were overcome, and the law passed allowing methadone to become legal. Now, becoming legal and being implemented are two independent questions. And in fact, the scaling up of Vietnam, in contrast to the scaling up in China, which I mentioned, went from 0 clinics to 5,000 clinics in a matter of a few years. In Vietnam, this scale up was very, very slow. And the first pilot program was to begin 2 years later in Haiphong, the third largest, I guess it's the third largest city in Vietnam after Ho Chi Minh and Hanoi. And because it was a port city, there was a lot of drug use and a serious opioid use problem. But even there, the pilot programs started very, very small and was threatened really with a problem that I think is a universal problem in the field of public health, and that's death by pilot. That it was never going to produce the kind of information and the kind of acceptance that was necessary to serve as a national model. And fortunately, through the efforts of people like John Hamilton and Wong's persistence at pushing the issue and working with communities of drug users who pushed the issue about the need for effective treatment for their opiate use disorder, eventually the ball got rolling and more programs were established. The last time I was in Vietnam, which was in 2015, we were actually expanding methadone from the urban areas to some of the more smaller cities adjacent in the provinces adjacent to Hanoi that continued to have opiate use problems, and working with local officials to encourage them and show them the data and show them the information about addiction and its proper treatment to get expansion really into previously underserved communities. I'm going to share just one more slide if I can figure out where it went to. Maybe I'm not going to share it since it seems to have disappeared. Basically, my experiences in Vietnam were absolutely amazing. The people were wonderful, supportive, and I was going to show a picture of me taken from the back of Wong's motorcycle, threading our way through traffic in Hanoi. These are experiences that stay with you for a lifetime, and I'm thrilled that a chance encounter with Wong because of a Yale World Scholars Program led to such wonderful outcomes for me personally and for the people of Vietnam. And now I'm going to let John sort of explain how he participated in scaling this thing up and getting this really to be a much more national program.
Thank you, Robert. And I have to just echo what Robert said. It had been a tremendously rewarding experience being over in Vietnam, and everyone from Dr. Wan to those Vietnamese drug user associations couldn't have been more gracious and welcoming during the whole time. But as Robert had said, it's a very slow process. There wasn't much change initially, and one of the greatest challenges, I think, was having to be patient. And that was something that I think that I had to really be cognizant of, because it's been 7 years. And as of last week, I'm still talking to Dr. Wan and having her be in a position to just give me good news that only because last year we had another government official come by in Connecticut again to learn our policies on take-home privileges for methadone. Only in this last year, only last week actually, did they start take-home privileges for methadone, which is a kind of a basic standard of care in Vietnam. So that's exciting. So we're moving in the right direction. Can everyone see my slides? Can you see them, Robert?
I can't, no.
Not
Try
yet.
again. Close out and
All right.
reopen the file.
All right, I'm gonna have Sue jump in. Sue, can you jump in and show the slides for me? Or I could try again. Let me see. Shared screen. Oh, I gotta do the share. Got it. Okay, wait a second. Maybe I can do this. Can you see it now?
Yes, we see it.
Oh, yay. All right. Thank you. Okay, so Robert did all the heavy lifting in getting things started, and there was a major issue with heroin addiction, and still is pervasive throughout Vietnam. Although in Ho Chi Minh City in the south, there's a significant issue, particularly with young adults with methamphetamine. So we had to do some training and some interventions for that as well. But as Robert had said, some of the greatest challenges is, I think, in a nutshell, Vietnam was where we were 40 years ago in this country, seeing addiction as a moral failing and not a chronic illness that deserves treatment, right? So that was the biggest challenge, is shifting the philosophy of care. So these compulsory 06 work camps were, as Robert said, where people were going for treatment. So a family member with desperation reaching out to the government asked them to help their loved one with a heroin addiction, and they'd be sent to these work camps where actually you'd stay and they'd be evaluated for the first 2 years, and almost everyone that was there 2 years would get evaluated for a recommendation for an additional 2 years. So many of the individuals stayed there for 4 years. And when I first asked about how they got this concept of this labor camp and work camps for addiction, I believe it was maybe Phoenix House or Therapeutic Communities of America had come across the other countries and Asian countries and shared therapeutic community models, which in some ways in this country are somewhat outdated because a lot of the issues were around confrontation and shame-based interventions. So they've modified them. They've even changed their name in this country to Treatment Communities of America, because therapeutic communities have such a bad stigma to them now because of those early interventions of ripping people down to build them up, until we finally realize people are pretty damaged and ripped apart by the time they come in. They don't need any more ripping down. So they took this job function of a therapeutic community, which is having people work to develop a work ethic with peer support and peer confrontation for 8 hours, and they put that on steroids and would have people working for 16 hours. If you ever see a bottled in Vietnam almonds, that is an example of some of the work that happened in these compulsory work camps. That was some of the work that they did. And as Robert said, it gets pretty complicated because it's free labor, and it became a challenge to then shift. So that's, I think it was the World Health Organization and the UN that put initial pressure on Vietnam to consider the fact that these compulsory 06 centers, as they called them, were truly not evidence-based practices and the standard of care for helping somebody with an opiate disorder. So what was the policy intervention? As Robert said, with a lot of his early work and recommendations with Dr. Wan did have a great influence in Vietnam. Her dad actually was Ho Chi Minh's right-hand general, and so it's a very respected family in Hanoi, and she was able to implement this restoration plan to implement drug treatment. This plan actually is the blueprint that we worked on, and Dr. Wan from SCDI, which I'll explain in a bit, was the plan to implement changing these compulsory work camps, which there are 130 of them. There were 130 at them at the time in 2014 around Vietnam, with 1,000 individuals in each. So there were 130,000 Vietnamese individuals who were struggling with opiate disorder that we were now given the charge, with the support and the blessing, and presenting to the National Assembly, the National Congress, a plan for conversion of these work camps to best practices in treatment, and creating, for the first time in the country's history, a voluntary drug treatment system of care. So the key player in this is an NGO, non-government agency called the Center for Community Development Initiatives, SCDI, which is the center, in fact, in which Dr. Wan is the executive director. The government partners are, it's the similar agency in the United States for SAMHSA, which is Substance Abuse Mental Health Services Administration. Their comparable agency that we were working with was initially in 2015, the Department of Social Evil Prevention and Control. So I think the name of the department speaks volumes to the understanding of seeing addiction as a moral failing. After spending time and actually bringing the director of the Department of Social Evil Prevention and Control to the United States, to Connecticut, to my system of care, to spend a week understanding what treatment was about, I think one of the greatest moments in really shifting the mindset, and they're good people just doing the best they can with the information they had at the time, but this person had an epiphany, if there can be such a thing as an epiphany in Vietnam, but he had an epiphany in Connecticut and told me, John, I understand now. You have to treat these people like human beings. As you say, you have to treat them with respect and dignity. And so he was so excited a year later when I came back to Vietnam to show me that he changed the name of his department from Social Evil Prevention and Control to Social Vices Prevention and Control. So again, slow and steady wins the race. Small progress, a small victory. And the other agency that's a larger agency part of that is the Ministry of Labor, War, Invalids, and Social Affairs. So these are the government partners that we were working with. The implementation plan partners, I was supported in 4 trips over to Vietnam by the Open Society Foundation, out of New York, supported my travel and my experience of going over to Vietnam. One of the trips, though, was by SAMHSA, Substance Abuse Mental Health Services Administration. When they heard I was doing this work, they wanted to get involved. So they actually have an office in Hanoi. So I work closely with some of the individuals at the SAMHSA Hanoi office to make sure that everyone was on the same page for this implementation. I mentioned SCDI, which is Dr. Wan's agency. I brought in CCAR, Connecticut Communities of Addiction Recovery, and I'll address that later because they had workforce challenges and they had no ability to train their staff because they'd never had a voluntary addiction treatment center. I brought in somebody called Dennis Daly, who's written many books on relapse prevention and recovery management at the University of Pittsburgh. I had worked with him with work that we did with National Institute of Drug Abuse, and he helped provide some of the training in the medical school. And I worked with a physician in France that out of Paris, who was a buprenorphine expert that worked with the Red Cross. And unfortunately, the buprenorphine is cost prohibitive for them to adopt as a medication compared to methadone. So we really went with more of a widespread adoption of methadone. And I worked with an individual Australian named Jay Jordans, who actually set up the community courts, similar to drug courts in Australia, to be able to help set these community courts up to do diversion in Vietnam. So instead of having people have to be involved in incarceration, that was very challenging, I mentioned before, because of the way the tiers are, that we didn't want to move away from people being voluntarily involved, but at the same time, we were trying to educate those in the court systems. Some of the specific training, because of the mindset for the group of being able to initially just see addiction as a moral failing, I thought it was really important to teach the individuals to focus on motivational interviewing, which is more of a collegiate approach towards treating people with operationalizing, in a sense, meeting people where they are, treating people with dignity and respect, having people be able to really have more of a collaborative relationship with those they're working with. We provided training also for in cognitive behavioral therapy as one of an evidence-based practices. We provided training to the staff and to the medical schools on the biology of addiction and recent findings. Spent a lot of time providing training on best practices in the full continuum of addiction treatment, and specifically giving people an education of what medication-assisted treatment and recovery is, and specifically methadone. The voluntary treatment system, that was the restoration plan, not only included methadone in the community, but also included detoxification. which we call now in our country withdrawal management, because detoxification is somewhat of a kind of a pejorative term. We were helping them with withdrawal management. We were helping implement outpatient services and community-based care, trying to provide some residential care where these compulsory O6 work centers were, to replace them with detox and residential and respite care as well, so that individuals could actually have a recovery environment, as we call it, to be able to start their recovery process. But the predominant work was rolling out methadone. The training targeted audiences included, and it actually segued well with the work that Dr. Heimer did in Hanoi with the medical school. I spent a great deal of time with the social work school, infusing a curricula that included alcohol and drug training. There's a program that is internationally accepted through, it's called ICRC, International Counseling Standards, for alcohol and drug training. It comes out to about 360 hours of training, and the experience of having 3 years would get somebody certified internationally or in respective countries as a certified alcohol and drug counselor. But again, some of the challenges is the workforce. No one had ever been in that field before, so they couldn't get their experience. But we thought it would be really important to be able to infuse the content of alcohol and drug training, particularly drug treatment and drug education, in the existing social work schools. One of the most important audiences to train and actually have them shift their philosophy of care was the compulsory O6 center staff. And again, the staff were eager to do a better job, because they don't have a confidentiality or HIPAA requirements in Vietnam. So when people came out of these work camps, they were shocked to find out that 95% of them went back to their drug of choice, which was generally heroin. Of course, that would be the case because they hadn't really provided any treatment, only just putting them to work for up to 4 years. So the compulsory work camp staff were very interested in being more effective and being able to help more individuals. I did several presentations to the National Congress, the National Assembly. I'm actually doing another one in a week from now to talk about screening and intervention and screening people out of the criminal justice system. And that again was very important to have, first, to have them adopt that policy of the restoration plan for the voluntary treatment system. So we actually had to present Dr. Wan and I for the adoption of that plan. But since then, we've had to give regular updates to the National Assembly of how that implementation of the restoration plan is going. We also train the staff, the medical and the public health staff in the community health centers in all the different regions throughout Vietnam. And as also mentioned, VCSPA is the name of the Vietnamese Drug Users Association that were very, very interested in learning how to help their colleagues and friends come off of heroin, in some cases methamphetamine. Some of the challenges that we had, as I mentioned, was philosophy of care. I think one of the biggest challenges was to have the understanding that addiction isn't a moral failing. It isn't a social evil or vice, but in fact, it is a relapsing illness that requires treatment. And the other great challenge is the workforce. How do you start a voluntary treatment system when you have no workforce? So what I thought would be the best strategy is to train those individuals that were drug-using individuals that were already on a street level, working with individuals, trying to help them. And that would be a great place to start, and teach them how to be recovery coaches. Some of our my implementation strategies that I tried to use is using implementation science best practices, which included some of the champions of this project. And we were providing this training and rolling out this implementation plan throughout all of Vietnam, but it took in some areas more than others. And one of the key factors in what took were the individuals that were very passionate and the champions of wanting to adopt best practice treatment. And one of the best champions was the director and co-director of Bac San, which is a province in Vietnam. And they embraced starting methadone, bringing in a detox, outpatient services. They were very excited about the potential of these best practices. So I brought the director and the co-director, who had, by the way, been the director of the 06 work camps, and now we're embracing best practices, to Hanoi, to the National Assembly, to speak about the success and their excitement about what they were seeing in the changes in having people actually start on methadone and turn their lives around. And I had those individuals also go to the other provinces that were not at the same level to help them adopt and learn what their strategies would be to help implement some of this voluntary treatment system with a group that was very, very enthusiastic. I think one of the greatest strategies that I used for implementation is having, since there was no voluntary addiction treatment system in Vietnam, I brought the government officials and the directors of these work camps and the individuals from SCDI, which is a big part of the technical assistance and workforce. And I brought them to the United States to have them see some of the treatment system in practice and have them spend time in my residential programs, in my methadone programs, in my colleagues' programs, looking at all of the different treatment programs that were operating, and have them be able to adopt the policies and translate them into Vietnamese and adopt some of the strategies. But most importantly, get to witness the counselors working with these individuals and what it means to screen someone, and talking to the nurses and looking at what it looks like to be able to adopt a methadone treatment and have that be something that's really effective, and that I think was most effective. The recovery coach model, I first started with someone named Anthony Eldridge, who is out of London, who's part of the international recovery coach movement. And then I brought in Phil Valentine, who runs the Connecticut Community of Addiction Recovery, who also does a lot of international training. And even though it's a Connecticut-based company, they have the curricula and the certification for recovery coaches through the United States. And I brought in a Courtney Lavelle, who developed the young adult recovery coach curricula because of the issues that Vietnam was having in Ho Chi Minh City with young adults. This is a group which includes Dr. Wan and Jay Jordans from Australia, who is fluent in Vietnamese, which is really helpful because everything gets translated. And this is the group. And some of the individuals here, even though this was in Hanoi during a presentation, were people that I brought from the other parts of Vietnam that had effectively adopted it. And in the middle is Sarah Evans from the Open Society Foundation. And that is Phil Valentine from CCAR, and Courtney Lavelle, also from, she's out of New York, that came in and provided the recovery coach training to individuals, not just with SCDI, but the Vietnam Drug Users Association, and it was very welcome. In one way that Vietnam is way ahead of the United States is they embraced easily harm reduction strategies and a harm reduction focus versus an abstinence-based focus. And this was me in my office, which I'm actually speaking at right now, with Juan and the director in Hanoi of social vices prevention, and he came over to learn what the policies were for take-home bottles. And as I just announced, we were able to introduce that in the last week, which was very, very exciting. So there were certainly some challenges as well. And some of the challenges, and here I am again with in our residential women and children's program, showing them what it's like to have a residential program. So that became some of the challenges that they had no idea what a residential program looks like and what that would mean. And it was really important for us to really be able to have them see it firsthand. One time I went in when we started the detox in Bak San, they were really excited. I gave them a 3 to 5 day protocol. Then I came back a year later and the director was all excited saying, well, initially we had poor AMA rates. People were leaving after 3 days when they were feeling better. And I said, well, but now they're better, the AMA rates. I said, well, how is that? I said, well, we decided we just locked them in their rooms and they couldn't leave after 3 days. So again, I had to explain to them that's no longer a voluntary treatment system when you lock individuals in their rooms. So that's just an example of like some of the nuances that they really needed to understand what it meant to have people have kind of the free will to come in and out of the treatment system. And 12-step recovery isn't something that's embraced in Vietnam, as it's mostly a Buddhist country, and 12-step principles are Christian Judaic and an overlay, as even decided by Wade versus Orange County in Florida, right? So refuge recovery was more embraced by some individuals for some of their kind of pathways to recovery. But as Robert said, the key to the recovery was getting the right medication, which is methadone in this country, and the adoption of a philosophy of care that treated people with dignity and respect. Thank you.
Well, wow, that was amazing, intense and very thorough. We really appreciate the information you guys have brought to the table, especially the comparisons that you've made within your presentations to some of the work we do in the US. I'm pretty sure we have a ton of questions. Some are already coming in, as I see, and it's just been fascinating. So let's just go ahead and jump right into it. The first question we have for you, and I guess this is for both of you, from Dr. Weiner. It says, in the US, methadone is so tightly regulated, it has to be administered on a daily basis at approved treatment centers. Is this any different in Vietnam? And can primary care providers prescribe it, and can more than one day at a time be provided? If so, what is the experience? I know that's a loaded question, but.
Well, I could jump in to say that, again, it is less regulated. And the good news, if anything came out of COVID, we found out, and Dr. Heimer has actually done some a study on this, is that because of COVID in my clinic and clinics around the country, the federal strict regulations of coming in every day for 90 days were loosened, where people who were in this country stable in recovery had up to 30 days, less than stable 2 weeks, and unstable they'd still come in weekly. And we found in our agency it didn't result in increased relapse rates. So that hopefully will allow those loosened regulations to continue in our country. But in Vietnam, they were able to be administered through the community health centers, but only recently, as I mentioned, were the greatest obstacle was getting take-home privileges, to have people be able to have take-home privileges. And one of the challenges in one of the provinces that I worked in was that what was happening was, once people were doing well on methadone and they went back to work, they'd have to leave the methadone program, because in the restoration plan, somebody actually turned the page and said, no, we have to start this program at 9 a.m. That's business hours. And I was letting them know in the United States, we have hours that start at 5 a.m. so people can come to work, can come get their methadone and go to work. But that was some of the rigidity they had. If it's not written in the plan, they didn't have flexibility. So sometimes people had to choose between a job and staying on methadone because they couldn't come in early. But there is significantly more flexibility in the sense of who can prescribe in Vietnam than the regulating bodies of DEA and Consumer Protection and SAMHSA and every other, and Department of Public Health in this country.
Thank you so much, John. We have another question from Slokar. It says, are there aspects of Vietnamese culture and history that could be or have been used to get buy-in from family?
I'll take a stab at that. One of the things that Wong's organization, SCDI, does is work not just with drug users and other marginalized populations, but with their families as well, to set up programs that give the drug users social status. My favorite example is there was one of their communities, or one of their centers was in the eastern part of Hanoi, across the river from the main part of the city. and they'd gotten a couple of drug users who were handy with tools to make objects in metal, to do welding for the community. And this all of a sudden changed the attitude about drug users enormously, because instead of being seen as a drain on the community, these people were now being seen as having value, and it gave them the social capital to allow their status, and not just their status as two individuals running this metal shop, but all the drug users, an increased status and acceptance as humans deserving of care within their community.
Thank you, Dr. Heimer.
And I would just say too, one of the areas in Hanoi, one of the drug users that went through the training, their family was so impressed by them turning their lives around. They opened their home to a drop-in center, like a recovery drop-in center, to be able to have individuals that are still struggling come to their homes. So it's wonderful that the family embraces, being able to be part of the solution.
Great, amazing, thank you.
We should be so lucky here in the US to get people stigmatizing their family members.
True, very, very factual. I have another question coming in from Dr. Joji Suzuki. Will sublingual buprenorphine be an option for OUD treatment in Vietnam?
I don't think in the near future, and it's all about price. When everybody looked at the actual cost, methadone for an average of 80 to 120 milligrams, the actual price of the methadone is about $3 a week. An average price of buprenorphine is about $80 a week. That is cost prohibitive for this country in being able to have widespread adoption just on price alone.
Yeah, it's even cost prohibitive in parts of the United States that haven't done Medicaid expansion.
Exactly.
Mm-hmm.
Good point, Robert.
Right.
No, absolutely. Okay, we have another one. Will safe injection sites ever be implemented in Vietnam? It seems like they would be very beneficial in the US, but even here, my understanding is they are not allowed. And this is from Sue.
Well, one of the trips I took with the training actually included bringing Liz Evans over. And we had a chance, by the way, to present at the International Harm Reduction Conference in Kuala Lumpur on the Vietnam experience. And then Liz Evans came back to Vietnam with us. Liz Evans started the Vancouver Safe Injection Site. And she believed that the spirit of those individuals that she worked with, that were the Vietnamese Drug Users Association, would embrace it in a heartbeat. But I'm not so sure it has been adopted yet formally. But I think they have a better chance of getting it adopted sooner than the United States.
Don't sell us short.
I actually had a question myself. You mentioned earlier about harm reduction and how it's being adopted essentially in Vietnam. Could you give us a few more examples? Because I heard you say that you feel like it's actually doing a little bit better or being more embraced there. Could you elaborate a little bit more on that regarding how you think that is going about?
Go ahead, John, you go first.
I was just going to say, for the methamphetamine trainings, for instance, many of the individuals that came to the training were still actively using methamphetamine. So some of the strategies was to create just a safe place for people that when they were having really bad responses and being psychotic in their symptoms, just to contain them and keep them safe, with no expectation or requirement to have to start to reduce or cut back on their use. And then again, a lot of times, as we know, even in our experience in this country, detox alone is not a formal effective treatment, that we were going to have these individuals that are still using follow people in the community to have them use safer, because many times they still struggled when they came out there because there wasn't, outside of methadone, many options, not a very supportive community of people in recovery that had them continue to use and then find strategies to use in a safer way.
Yeah,
I was going to add that harm reduction is is kind of an umbrella term, and it's defined differently by different people. There are certainly elements of harm reduction that were readily adopted in Vietnam. They've long had syringe exchange programs, and they've, but on the other hand, their 06 camps and their criminalization of drug use, is not a harm reduction focused set of policies. So, answering that question depends on which element of harm reduction you really want to talk about. And just like the US, we're good on some things and we're bad on other things. There is no country that's perfect when it comes to harm reduction. So, I mean, it just, there is still the tendency everywhere in the world, after 100 years of criminalization and international conventions on drug use, to see drug use first and foremost in a criminal justice lens. And changing it to a medicalized lens also is incomplete, because for the majority of people who use drugs, they don't develop medical problems when they use drugs. So, harm reduction ought to start from looking at the impact of individuals' drug use on themselves, their families, and their communities, and minimizing the harm at all three levels. That's a tall order.
Yeah, no, that makes sense. Dr. Suzuki kind of had a question, and I didn't even see this prior to my question, which is very similar, only he's asking, what is your sense of Vietnam and how it compares to other Asian countries in terms of the adoption of harm reduction?
Well, thank God it's not the Philippines.
Okay.
I mean, I'm not enough of a comparative, person to tell you. Obviously, there are places that surprisingly have adopted harm reduction elsewhere in Asia. The best example may be Iran, which, despite having a repressive regime, was open to harm reduction and methadone and needle exchange 20 years ago, and still has those services for drug users, and still integrates HIV care, methadone, and needle exchange at the same facilities. And that's one sort of extreme within an extreme, where the policies are much more liberal than the general tenor. And then there are places where, despite the general tenor being fairly open, the response to drug uses are tremendously draconian, like Singapore.
Okay.
So I don't think there's an easy answer to that question.
Yeah. Thank you. Thanks for trying.
Thanks for failing.
I mean, I understand harm reduction does sound like it wears different hats, and to your point, like, depending on where you are, it could mean different things. So it definitely makes sense.
There's a principle in harm reduction that says you have to meet people where they're at. What it doesn't say, and what it should say, is you have to meet institutions where they're at. And sometimes you can change the institutions, and sometimes you can't.
Yeah.
Absolutely. Yeah. We have another really great question from Sue. It says, what are some of the most important operational research questions about OUD that we can work on in order to move policy forward here in the US towards things like acceptability of safe injection sites, more widespread use of buprenorphine movement away from involuntary treatment?
Let's start with the most politically charged one at the moment, which is safe injection sites. Needle exchange, syringe access was 30 years ago just as politically charged. And what happened was that people didn't wait for government to endorse such policies. They went out and took risks on their own. And some people got jailed. Some people lost their livelihoods for doing this. But in the end, most of the time when the better good argument was made in court cases, criminal cases, trying to prosecute people who were running needle exchanges, the sentences were either thrown out or not imposed or very light. So I think it's going to require, for that issue, activists, drug user groups taking the lead and working with the public health community to provide them with the expert testimony to back them up when they get hauled into court.
And I think there's a real opportunity with all the new resources coming in post-COVID for behavioral health and looking at the fact that the opioid epidemic didn't get the memo about the pandemic and continue to increase, that there is going to be, at least in Connecticut, I'm hearing about half of the money that's coming into the state's going to go directly to municipalities where there is local support in some communities for safe injection. And I think we are really moving in that direction. We've, been providing training to the state through DEMIS and policy change. We actually created a policy change in Connecticut with the alcohol and drug policy most recently to have all the policies be more consistent with harm reduction policies and practices. But it's again, as Robert said, it's in meeting systems where they're at. Not everybody's on the same page. I do think, though, the issues around police reform and training offers great opportunity. I'm spending a lot of time in my agency partnering with law enforcement for early diversion lead-like programs to keep people out of the criminal justice system. And so law enforcement, I think in some ways, is even more, in general, my experience, adopting or welcoming of harm reduction. They know what they're doing isn't working. So I think the challenge is to try to have earlier interventions before getting people involved in the criminal justice system, earlier diversion. So even Dr. Wan's not a big fan of drug courts, and there's something positive I did. I'm on the New England drug courts in the New England states, and we got them to finally change their name to New England Recovery Courts. But it just helps a couple of people. I'm not really a big fan of that really having an impact on individuals. I'd rather see pre-prosecutorial diversion programs that we've started in Connecticut to identify with a special prosecutor individuals who have drug offenses and giving them options for treatment and not giving them a criminal record and being able to not have them be charged. And then again, pushing it back to a bail commissioner's office, treatment and pathway programs, getting people out of the criminal justice, not to touch the criminal justice system on the front end. And I think more policies and more opportunities are happening there, which I'm hopeful for.
Thank you so much. That was a wonderful, wonderful answer. I want to, because we only have a couple of minutes left, but I wanted to get one in for myself. I wanted to ask, what I know you guys have been doing quite a bit of work for a while now, and I heard you say earlier in your presentation, a little kind of goes a long way. It's almost like, something's better than nothing. Kind of like what you just gave us an example of, just changing the word drug to recovery. Mm-hmm. What would you say that your biggest successes are, or give me your, maybe especially both you guys working together, what is your most greatest singular success, would you say, working in Vietnam in this space in particular? And then maybe you can follow up with what would you like to focus on? What is the singular thing that you like to focus on moving forward?
Did you want to go, Rob?
I mean, my involvement was very early on in the process, just getting the National Assembly to legalize methadone and open the door was in Vietnam was my greatest success there. My second greatest success was being on the back of Wang's scooter and not dying.
Yeah, that would have been a success for me too.
Yeah. I found a great success just walking across the street in Hanoi, that cars and scooters go by you, and it's this principles of harmony. So you can't stop; you just have to move.
You're praying for your life the whole time.
Although it's interesting, if you ever cross the street in New York City in a crosswalk, people manage to not walk into each other.
Yeah,
Mhm.
yeah.
In Vietnam, they can do this at 30 miles an hour on their scooters and not hit you.
Yes.
Yeah. Yes.
It's incredible.
It's really, it sounds incredible.
I would say tangibly, what I think is one of the greatest successes, having a part in getting this. So there was 130,000 people in when we started this project, 130,000 people in these really, and sometimes even abusive work camps that were really horrific, right? For 4 years, we got close to 100,000 out. And unfortunately, there's still 30,000 that are still in these work camps that haven't converted yet. But I think that's progress. And I'm still committed to continue to go back and help out any way I can be helpful.
Well, thank you so much, Dr. Heimer. Thank you, John, for joining us. We are definitely out of time, but we wanted to just let everyone know that, first of all, thank you everyone who hung around. And we have this happening one more time next Tuesday at 12 p.m. Eastern Standard Time. Our speakers will be featured from South Africa and Portugal. Thank you all again. Really appreciate it. And you'll be able to see the recordings for all of these, both on the Poppy website as well as the center's website. Okay.
Thank you.
Thank you, everyone. Have a great one.
Bye.
Bye-bye.
Bye. Thank you.